Hello, everyone. This is Dr. Shaimal Khoui. I am from Egypt. I am from Cairo University. I'm one of the team of the Advanced Intervention Endoscopy. I'm really happy and honored to be here today with you to present my team and to give a little bit of speech about achalasia, which I think from my point of view, it's not a nightmare anymore. So my agenda today, I'll speak about what is achalasia and what happens to you if you have achalasia, what could be the possible causes of achalasia, how we diagnose it, and what are the treatment options for achalasia. So let's start. What is achalasia? Achalasia is a very rare disease. It's really a very rare disease. It's like one person per 100,000 people. The word achalasia means no relaxation. That's a Latin word that means no relaxation. So you can guess from the name what is the disease. So it's a non-relaxing disease. So here is the esophagus. This is your food pipe. And here's the stomach. And here's the muscle between the esophagus and the stomach. This muscle is called the cardia, or the heart of the stomach. What happens in achalasia is that this muscle, which we call the cardia, is very tight. It does not relax easily. So you can see here's the lumen of the esophagus here is much wider than normal. So for the food, as you can see here, the food comes from your mouth down the esophagus. It passes the muscle and then reaches the stomach. But in cases of achalasia, the food bolus comes like this. And when it comes to the muscle or to the cardia, it does not pass easily. Okay, and the food stays as it is in the esophagus. So this is simply what is achalasia. So if you have achalasia, what happens to you? First, you have difficulty in swallowing, which we call dysphagia. Difficulty swallowing actually is one of the red flags that we have in GI. There are some few symptoms when the patient says, I have difficulty in swallowing. This is a red flag that we have to push the patient to do endoscopy to see what's going on. Second, because the food stays in the esophagus, sometimes those patients have chest pain, which may be wrongly mistaken as a heart attack, but actually it's simply achalasia. So we can have regurgitation and heartburn because the food also stays in the esophagus. Regurgitation here means that after you eat, you feel that the food comes back into your mouth. This is regurgitation. Sometimes in severe cases, you throw up. There is a vomiting or there is a throwing up. And this throwing up is really a kind of relief. So if you're not eating properly, if the food comes back into your mouth, if you feel pain in your chest, eventually you will lose a bit of weight. So one of the most terrible symptoms that achalasia patients have is that they really cannot sleep at night, because whenever they sleep back on their back, they feel that the food comes back and they have choking. So they usually put a lot of pillows, or they can sleep in this semi-sitting position. Sometimes also they have like repeated infections in their chest, and some of them are wrongly diagnosed as having asthma, and actually it is achalasia. When the food stays in the esophagus, the bacteria comes to it, and then you have a bad odor in your mouth. So in some cases, in a long-standing achalasia, when you have achalasia for many years, there is an increased risk that you get cancer if you compare it to the normal population. So here is the ICART score. This is a clinical score that takes into consideration the main four cardinal symptoms of achalasia, which is difficulty in swallowing, regurgitation means the food comes back into your mouth, pain in your chest, and weight loss. It puts you on a scale from 0 to 12, where 0 is normal and 12 is severe achalasia. So what causes achalasia? Actually, it's caused by like the nerve supply to this muscle gets damaged. But what causes this nerve damage? Nobody knows. There are some theories like viral, in fact, it's a virus or it's an autoimmune disease, but actually nobody knows. So as long as the cause is unknown, there is nothing you can do to prevent you from having achalasia. You just have to deal with the disease. So how we diagnose it? We diagnose achalasia using 3 tools. We cannot use a single tool of it only. We have to use the 3 tools all combined together. First is endoscopy. As you can see here is a dilated esophagus with retained food, retained fluid, and there is a narrow cardia at the end. And our second and third tool is the barium swallow. Barium swallow is just a white dye that you ingest that gives a picture about your esophagus. High resolution manometry is our third and is a cornerstone in diagnosing achalasia, as it just doesn't just diagnose achalasia, it also measures the pressure inside and it tells you exactly what type of achalasia is this. There is different types. We have different types. They are not grades. So they are different types of achalasia. Here's type 1, which is the classic achalasia. Here we have a tight cardia, very wide lumen, and here is a zero pressure in the esophagus, as you can see here in the manometer. Here's another form, which is a type 2. The problem is not only here in the muscle, no, but it's also there is a high pressure area in the esophagus. We call it pan pressurization. Here you can see there is a high pressure in all the esophagus. Then comes type 3, where there is not only the problem in the cardia, but we have like spastic rings all through the esophagus. So these are the 3 types. Type 3 is the rare type of the achalasia. So how we treat it? There are some old forms, which is the drugs. There were some medications taken to relax the cardia, or Botox injection, which has a very temporary effect. But actually, all the international guidelines now are all against, because this is not a definitive treatment. It's not a logic treatment, and it delays the patient to take the actual step of treating their achalasia. So if we're thinking of more effective solutions, you have to deal directly with the muscle. You either stretch the muscle, which is balloon dilatation, or the more definitive, which is cutting the muscle. Cutting the muscle is either with surgery or the new procedure, the very famous and new procedure, which is POEM procedure. Here's how we do balloon dilatation, or just stretching the muscle. We just put a guide wire and we slide a balloon over the guide wire and we do some dilation. Dilation is suitable only for type 1 achalasia, not for type 2, not for type 3. And unfortunately, you will need some more sessions. And actually, this is not, at the end of the day, the definitive treatment. Okay, if you go to the definitive treatment, there's Haller's surgery, where you cut the muscle. This is a very famous old procedure, like 30 or 40 years ago. And here comes the POEM, which stands for per-oral endoscopic myotomy. POEM procedure is a new procedure. The first cases were done on human were in Japan by Professor Inouye in 2010. And since then, it's a very famous procedure because you can do the myotomy, the surgical Haller's myotomy, using the endoscope, not the laparoscope. So there is no scar from outside. You can drink early, and you can also go home early. And POEM also added benefit that it could deal with other types of achalasia, like type 3 or type 2 achalasia. So how is POEM performed? This is a video from Johns Hopkins. It states how POEM is performed. Here's the endoscope, going from the mouth, reaching the esophagus. We create a tunnel in the wall of the esophagus, reaching to the cardia. And then we start cutting the muscle. In POEM, we can choose the length we cut. It's unlike surgery. The surgery myotomy length is limited, but in POEM, we can choose the length. After cutting the whole length of the muscle, we just go out and we can see here the lumen is widely open, and we can then easily close this tiny opening with just few endoscopic clips. This is how POEM is performed. This is one of our cases, live cases. Here, 10 centimeter above the muscle or above the cardia, we do that bleb, and then we start creating an opening of the tunnel. And then we hinge our scope to go through the tunnel. And we start dissection till we expose the muscle that we want to cut. We continue on dissection, injecting and dissecting. And then afterwards, the tunnel had been created. We start cutting the muscle. As you can see here, we cut the muscle. The muscle is very thick. This patient was really suffering. And after we cut the muscle, you can see here, it's finally cut. Then we close the small opening with few clips, and you can see the lumen of the esophagus is intact. So you can start drinking next day. You can see here the cardia with the muscle before and after POEM, it's widely opened. So the results of the POEM are very promising. Regarding the safety profile, it has a very high safety profile, reaching 100%. Regarding the technical success, which means that an advanced intervention endoscopist is able to complete the procedure, is really reaching near 100%. Regarding the clinical impact or the clinical success of the procedure, according to the data available or the published data, it ranges from 93% to 100%. So we think that POEM is really taking over now in managing achalasia. This is Zhongshan Hospital, Fudan University in Shanghai. This is the center of POEM in the university. There, they performed more than 6,000 poems. Here is Professor Ping Hong Zhou. He is the master of POEM in the world. He was our mentor, our trainer. We received, the three of us, me, Dr. Mohammed Sharbini, Dr. Karim Assam, training in Shanghai. We've been there. We received training there on humans. And then afterwards, when we came back to Egypt, they sent us Dr. Tsai to just monitor us during our first cases of POEM in Egypt. She was really proud of us, and it was really a nice experience. It was a life-changing experience. Now our team, fortunately, successfully performed 176 cases of POEM, which is quite a huge number for this rare disease. Our team could perform, we think that there is no obstacles for POEM. We could perform POEM in extremes of age, like 2.5 years, this tiny little girl, this old man, 86 years old, and they are both doing fine. So age is not a problem. We could perform some difficult and tough cases. We can see here the esophagus is hugely dilated and it forms like a loop, This is long-standing achalasia. These cases were in the past very difficult cases. You remove your esophagus and you put your colon. Instead, very tough operation. So we could successfully, thanks God, perform POEM to those patients. Here's a very nice picture of a very difficult and challenging case. You can see here's the esophagus. It's just like a Z-shaped esophagus. And here's completely closed. There's no dye coming into the stomach. It's really very difficult to perform it in this unstable position. However, thanks God that we could end the suffering of this patient. So we could also perform POEM after failed Heller surgery. You can see this patient, he had a Heller surgery who failed, and he had successive balloon dilation afterwards. And then all the doctors, he consulted them, told them you have to go and open your chest, remove your esophagus, and do a colon bypass operation. There's nothing that you can do with endoscope. There is nothing you can do to the achalasia anymore. So this patient was quite desperate, and he was pushing us to perform POEM for him. And we did. We performed POEM. As you can see him, before and after, how he's happy, how he put on weight. He put on like 16 kilos. It was really nice, and this is an unforgettable experience for the three of us. We could also perform POEM in patients who had sleeve gastrectomy, which is very rare, and this is a very different situation. We could also perform POEM to a case who had POEM before with another doctor, not from Egypt. And then this patient had a recurrence, and we successfully performed a re-POEM procedure for him. And he's really happy and appreciating this. So it's very important that we know there is a golden rule in managing achalasia, which is early management is the best management. Please, if you have symptoms, if you have anything, you have to go and consult your doctor to know if you have achalasia or not. And if you have achalasia, don't hesitate. Early management is the best. Moreover, that POEM is now the classic treatment for non-achalasia cases. This is the esophagus. We call it diffuse esophageal spasm. This is a rare disease in the esophagus. The problem is not in the cardia, but the problem is in the esophagus. There was no cure for those patients. So now POEM is a genius solution for those patients. So POEM can be done also for non-achalasia cases. So our team now, we are considered as a referral center. We have done a lot of cases from the MENA region, Sudan, Yemen, Iraq, Algeria. And moreover, we have done a case from Chile. The patient, she came along from South America to us. This was really an honor. And this is a photos of our patient. This is really a very touchy slide for us. This is really very touching. Those patients, we have shared a lot of moments. We have shared their suffering. We have shared happy moments with them. They ask us all the time to put their photos in the presentation and to put them on our timeline, because they want to give a message of hope for every patient with achalasia. Our patients are forming like a small community where they communicate with each other, they support each other, and they help each other. And at the end of the day, when a patient comes to you and tell you, doctor, thank you, I can finally eat, or I can finally sleep, this is really priceless. So here is our patient, one of the toughest cases, Dr. Ahmad Safwat. He is the admin of the achalasia support group, and he is really working sincerely from his heart. He wants to end the suffering of others. He wants to help others. Thank you very much for your innovative ideas and creativity. Really, thank you. So this is our page on Facebook, Form an ESD Egyptian Club. We are now having more than 5,000 followers. You can just search for it and you can follow to see more operations, to see more patients, and communicate with us. And finally, this is our team saying to you, thank you. And here are our contacts. Thank you a lot.